Hello everyone. Welcome to this third research clinic in Arcade project. This research clinic is one of the experimenting which we have started some 6 months before in Arcade to give exposure to PhD students and faculty so that they can get information on their subject from different our Arcade partners. And I am Dr. Vishal Diwan. And this third research clinic, in this Dr. Sarika Chaturvedi, who is Senior Program Associate in Matin Project in R.D. Gardi Medical College, Ujjain. She is also a doctoral student at Karolinska Institute in Sweden, and she is working on quality of care aspect in maternal care. And today's her presentation is about quality of obstetric referral services in India on Janani Sayogi Yojana or Janani Suraksha Yojana cash transfer program for institutional birth. And she will present this referral study, which is published in PLOS 1 in May 2014. And Sarika will present this study for about 20 minutes maximum. And then Saeed Abbas, who is also a PhD student in IDS United Kingdom, and where Saeed Abbas will discuss issues related to Dr. Chaturvedi's presentation. And then the discussion is open for other participants. So now I invite Dr. Chaturvedi for our presentation.
Hello everyone, am I audible? Thank you for this opportunity to the Arcade team. It's my pleasure to share the study of referral services. This was in the context of the Janani Suraksha Yojana, that is called as JSY. JSY is a cash transfer scheme, that is women are given cash to when they deliver in health facilities. So my study is focused around the scheme called JSY. And the study was done in one part of India, that's in central India, that's called Madhya Pradesh province. So just to give a context of the program, India had a very low proportion of mothers delivering in institutions prior to 2005. And that was when the government thought of having the JSY program to bring mothers to institutions. The logic was that by doing this, women will have access to competent emergency obstetric care, that's called EMOC. And by that time, it was well known that access to competent EMOC can reduce maternal mortality, it can save lives of mothers and the newborns as well. Hence, this focus was on JSY to increase access to EMOC. So JSY was launched in the context of a health system where in India we have, like in the UK, a three-tiered health system structure. We have primary care centers, PHCs, then secondary care centers, and tertiary level district hospitals. So for JSY to be able to reduce maternal mortality, it was important that this referral system is well functioning. And that is what the study set out to examine. Also, an important aspect in this was the referral transport. So along with the JSY that gave money to women to bring them to institutions, we also had a referral transport scheme that women had access to a free transport when they called, when they needed to go to hospitals or even for interfacility referrals. To start with the study, we use the Jahan's model of referral chain. So basically people generally think of referral of just the transport part. But to elaborate, referral has three components: center level facilities, transport component, and the receiver level facilities, that's the referral hospital. And there are multiple factors that affect the different levels of the referral chain. In this context, the paper we published is much broader and has much more matter than I'm able to present in this short sessions. So I'm going to present only on the objective that about the quality of referral services. So we examine this by studying the association between maternal referral and adverse birth outcomes. And secondly, by looking at the spatial access to EMOC among mothers who were referred to a referral hospital and they died there. So I'll present each objective, methods for each objective and the results accordingly. So first objective, we had a nested matched case control study. And this was in 3 districts of Madhya Pradesh. The results varied a lot among the health indicators. We had a cross-sectional facility-based study. So we took facilities that conducted at least 10 deliveries a month. There were 96 such facilities in the 3 districts. And then at each facility, we spent 5 days to interview mothers who had delivered there. So in total, we had 1,182 mothers. As you can see from this table, we had 96 facilities, including all levels. The last row presents the private sector, which are not part of the JSY, but included in this study because women also referred to private hospitals. And then the second column presents how many mothers we saw at each of these levels. This slide shows the total of 1,182 mothers. So we see that the circle at the bottom on the left, 1,071 mothers came from home. A few, 111 were referred from some facilities. And then some of them were referred out of the facilities we studied. And then we have outcomes for 1,113 mothers who received care at the facilities we studied. So my case control study is based on the outcomes data for this 1,113 mothers. So coming to the case control study, we defined cases as mothers with adverse birth outcomes at a full-term delivery. There were 34 such cases. Controls for mothers who had live neonates at 48 hours postpartum. We had 68 controls for the 34 cases. Controls we were matched individually to cases for the type of complication and for the place of delivery. The reason for choosing these 2 parameters was because outcomes could differ much based on the type of complication that the mother had and on the place or the level of the facility she delivered. So these were the matching criteria. An adverse birth outcome we defined as an intrapartum death, fetal death, or an early in-facility death, that is death before 48 hours of delivery. This table presents the characteristics of cases and controls. So age, literacy, parity, type of delivery didn't differ much among the cases and controls. But as we see, there was a significant difference among cases and controls for the proportion referred. 50% of the cases were referred against 25% among controls, as well as more poor women in the cases. This slide shows the output of the conditional logistic regression model that we used to examine the association between maternal referral and adverse birth outcome. So controlling for age, education, poverty, parity, ANC care visits, and the type of provider who conducted the delivery, we found that maternal referral had about twice 2.6 is the odds ratio. That may higher odds of adverse birth outcomes. That's about the first objective to study the association. Now looking at the second objective, which was about the spatial axis. This was studied through use of GIS, that is Geographical Information System. The UN standards for geographical access say that 2 hours of travel time to a comprehensive EMOC, that is where the facility has access to blood and cesarean section, that is considered as a standard of geographical access. So we use this standard to study spatial access. So we consider 2 hours as the desired travel time to determine spatial access to EMOC services. So this study was in 1 district. So we identified the facilities, CMOC facilities, that was 1 district hospital in this study using the UN signal functions. So the first step was to digitize the map and look at the roads and the facilities that this district had. So this is the map. The green crosses are the facilities where they have delivery services in this district. And there's the 1 red cross That's the one CMOC facility, that is where blood and syringe section and higher level services. That's the referral hospital in this district. So at this district hospital, we took data for 2 years from the maternal death records there and reviewed those records to find 124 maternal deaths. Then focusing on the referral part, we segregated to look at identified deaths among mothers who were referred. There are 55 such mothers who were referred and then who died at this hospital. So from the records, we mapped the locations of the facilities that had referred these mothers. So in this map, we see 55 dots that represent the mothers. Each dot is a deceased mother. And then the dot is placed at the facility where she was referred from. And all of them died at the Red Cross, that's the district hospital. So we see that mothers who died there had come from different CHCs within the district and a few also from the neighboring districts, which is in the white background. There were some mothers who came also from the district hospital, which didn't have the CMOC facility, that's the Blue Cross in the neighboring districts. So the next step was to do the buffer analysis of referring facility locations. So buffer is, I'll show you in the next slide. But to do that, we had to convert the time into a distance into time. So we took the average speed for a van in the study area is 50 kilometers. This was from the data we gathered from triangulation from nurses, our own visits, and from the van drivers. So with this equation, we made the buffers. We constructed the buffers around the Red Cross, that is the CMOC facility. So the purple ring in this slide, that's called the buffer. So it has a center at the CMOC and it is at a distance of 100 kilometers from there. So we see that all of the dots fall within the buffer, within that purple ring, except one. So which means that almost all the mothers were referred within that 2 hours of travel time. In this slide, we see the green circle is the 50 kilometers buffer. So we try to have a buffer at 50 kilometers, and we see that most of these mothers inside the buffer, they came from within 1 hour of travel time. So we see that from this analysis, it's that almost all of the mothers who died, they came from within 2 hours of distance. 82% of them came from within 1 hour of distance. And from this record review, we also found that the time between the arrival of the mother and the death was 6.75 hours median time. So to summarize the results from both the objectives, we found high odds of adverse birth outcome associated with maternal referral, and there were maternal deaths despite special access to EMOC. So our conclusions are that there are inefficiencies in the referral services, resulting in loss of life-saving opportunities. The system somehow failed to provide successful emergency obstetric care, and there could be possible deficiencies at either of the levels in the referral chain. Could be at the sender level, could be at the transfer level, could be at the receiver levels. But all in all, the results show that the quality of referral services in the JSY is unacceptably poor. We acknowledge the support for the study from the EU grant to this project and also from the government of Madhya Pradesh, as also to all my colleagues and study team members who have helped for the study. Thank you.
Okay, thank you, Sarika. And now I invite Abbas for his questions.
Thanks very much for your presentation, Sarika. And it seems to me that, it's a very nice presentation, but it did not do justice to the amount and richness of data and information in your PLOS One paper. So, because I find that, you've addressed multiple aspects of the referral care services system. And obviously, the presentation was a very small summary. Carrying forward from that, I think even looking at this paper, there's a lot of data lot of information and possibly enough information for 2 to 4 different papers. That's summarizing into one. So what? I mean, my first major point is that you can possibly. I think you would have more information available with you in your records and your experiences. So had you branched off, maybe divided your study findings into 2 or 3 different papers, you might be able to come up with even more richer analysis of the data information that you have with you. That's the first point. So I think it's a good feedback to have in any case.
Yeah.
And I mean, no one's stopping you from publishing further, right? So in any case. Second point is, you refer to issues around effective referral services, right? But you don't really define what do you mean by effective or efficient referral services. Do you mean effective in terms of outcomes and deliveries, or do you mean effective in terms of service types, or in terms of are there any other benchmarks or standards available from other countries which you would like to replicate and compare with? That's the first point. Second point was that about the objectives of your study. I think they're very well thought out and very well cataloged in your paper. But and I can understand, the need to focus on the negative outcomes or maternal deaths for your second objective. But if you had access to information on the non-deaths, the positive outcomes as well, I think you might have come up with even more richer data about how the system works. Then about GSY in Madhya Pradesh specifically, it would be good to have some sort of an idea about the health system's architecture in the state, right? What's the size of the private sector like? Is it really small for all services, or for obstetric services, or the number of you mentioned something about the distribution of the PNC, CHC in the district hospital over there. What kind of private services are available? There's a medical college you mentioned in your framework, right? So where is situated, and now what's its equations like with the district hospital and the referral services? Something along those lines would actually help to inform what the story behind the flow chart that you have describing where the different referral contacts took place. And also about you make a mention on several occasions about possible reasons why patients have been referred from one level to the other, even though they should have ideally been treated in that facility, right? So if you can in this study or something focus on the quality of services available at different facilities and how they can be a determinant in influencing referral, maybe improper referral, if you can say that. One way could be to look at IPHS norms and see whether these facilities are following IPHS norms or not, the Indian public health standards, or some other way of assessing the quality of services over there. It could be through exit interviews or patient surveys, whatever. So another factor could be the availability of workforce. I have been off the grid with regards to maternal child health issues in India for some time. So I'm not sure if the FIU term is being used. First referral unit concept. When NRG was initially launched, they had setting up FRUs at all the CHCs, right? So the CHC should provide 24 hours first referral unit services. Can you hear what I'm saying? Hello?
No. The audio is not yet clear.
Okay. Let me try to come closer to my microphone then.
So, Abbas, my suggestion is now maybe Sarika can reply these your questions?
Sure. I mean, did you gather all the points that I mentioned, or would you like me to go over some of them again?
I could get the IPHS point and the workforce. I didn't get anything after that.
Okay. Yeah, so I was talking about FRUs, the concept FRUs is still being operationalized in RHM. So again, I'm not sure because I'm not, current with the latest discussions in the country. So maybe comment on that, and maybe we can go over the next round of points and questions afterwards after you had a chance to address these.
Okay, sure. So thank you so much, Dr. Abbas. This was really interesting points to hear, specifically once you've finished the study and you think you've done everything you could do. So this was nice to hear. Yeah, I do agree that this is a very lengthy paper, and I chose not to present everything in the paper in this short presentation. And we did think of having small papers instead of one large paper, but the point was it was not coming as a whole story. So to come at, if you didn't have the outcomes, then the reviewers feel that you're just having a descriptive paper. If you don't have the descriptive paper, then say we need to have a background for your outcomes. So that was how we ended up having a long paper with so many components put together. But I agree that this could have been more. We could have used more data and make it into small papers, and that's a learning for me. Your second point was about how we define effective referral services. So when I use the Jahan's model, I haven't elaborated on that in the paper, but what I imply was that the referral services should end up having successful care. So senders should be able to send at time, transport should be efficient, and finally there should be good quality of care that results in what is medically possible, good outcomes in that particular case. So it is an outcome of a continuum of care at different levels, and finally a good outcome what is medically possible. Your point was about if we had more description of how the system works. So yeah, we could describe more, and there are a lot many things that could be said about the health system as such, and especially about the private sector, which we haven't said much in the paper. But specifically in Madhya Pradesh, the sector is really small in terms of how many obstetric centers operate. And I've just made a brief mention that the sector is very small in terms of concentration. It's very urban concentrated, and when I was looking at this, since it was the JSY context, which has very few private hospitals in it, it's largely the public system that is working for JSY is operating through. So that was the reason I had to make a choice not to write much about the private sector in this paper. Yeah. And your point about the Indian public health standards, yes, that's an interesting way to look at the functioning of these facilities. But one reason I would hesitate is that the standards only look at what are the structures available in those facilities. Whereas, as you know, the problems nowadays are after the NRHM are more with the processes. We have improved much on the structures. Like, they are not ideal, but they are much better than they were before 10 years back, before the NRHM. But the real issues that I find from this study and from the other studies are with the processes. So what happens when there is everything? There's the labor room, there's the operation theatre, there's the required number of staff there. Everything is in place, but then those systems finally don't work because maybe there were reasons as I've described, like people are not motivated to work, they are not competent enough to work, and actually no one cares about the quality. It's just that one more mother to be delivered and that's finished. So one JSY number has increased, we have had the institutional delivery, that's achieved. So no one is really bothered about the processes that happen, and there are the real issues I think now that we can improve on. Yeah. So I have more points from you.
I think so. I mean, this is very useful. And as you mentioned, those are the real issues, the softer aspects about the processes, how and why, they're supposed to be working and whether they're working or not.
Right.
And maybe that is why, even in your paper, while you talked about a lot of issues around referral services, the bigger picture issues, I think the minuting, for example, if you look at the figures 3 and 4 in your paper about the referral ins and referral outs, the whole chain.
Yeah.
It will be very interesting to see the stories behind, how patients got referred to or why were they referred to. Maybe through some illustrative case studies, or maybe an examination of the decision-making factors that that actually couple the healthcare worker at that level to refer patients to the next level, right? So, while all this is big data, in terms of averages and bigger picture, the smaller the more distant stories tend to get lost. So I think if you supplement maybe or follow this study with a more so less of an extensive but more of an in-depth assessment and maybe a qualitative assessment of what actually happens at select facilities, I think it will be really good. And you tapped onto that comprehensive EMOC facility at one district, right, which is supposed to be getting a lot of referrals. So that could potentially serve as a study site for you in trying to find out, what are the reasons why patient got referred to this was.
Right. Yeah, I agree, and that's really going to be interesting. So all in all, you've studied one aspect, and now you think it's important. There's more to study on this. So I think that's good. And we haven't looked at why the decision-making process around referral. But just to share a little bit brief about what idea I got from another study, which I did in the same facilities in these 3 districts. We're studying the competence of staff to recognize the complication and to give the first line care. And we had written responses into case vignettes from them. So what we found was that the real problem is that they're not able to recognize an emergency when from the case that they presented, they were not able to identify that this is the mother who needs referral probably. This is the one who needs maybe a first line drug that is an emergency drug. So there are real problems with staff having to make a decision about correct referral, appropriate referral. Whereas there were referrals when there's no reason, there's no logic to refer, then the reason when you don't know what to do is refer. So it's basically the football game that you just kick her off from the facility and then she goes further and further. But the district people are at the end, so they have to receive and do whatever they can. So that's the feel I got from the combining the 2 studies. But I agree it would be very interesting to look into more deeper qualitative study of decision making into referral processes and maybe look at both aspects from the user as well as the provider side of the thing. Yeah.
The reason being referred to in your figures 3 and 4, the referral ins and referral outs, that for different institutional actors, the medical colleges, the private hospitals, right?
Yeah.
So I think that is also going to be quite interesting to know.
Yes.
We took some. I was not aware of the benchmarks about the 50 kilometers versus 2 hours drive. But when you're doing GIS mapping, if you have access to road network data as well, right? The national highways, state highways, the Pakka roads and the Kacha roads.
Yeah.
So if you have access to these road maps, and if you can figure in something about the topography of the states or the quality of can you hear me now? Hello?
Yeah. Hi,
Yeah,
Abbas?
yes. Much better.
Oh, excellent. I switched off my webcam, so maybe...
Yes. Yes, go on, Dr. Abbas.
Yeah. So...
Yes, about the road quality.
Yes, so if you have some more data on the the spatial data on the quality of roads and road networks, it might give you a much better idea about what should be the time for taken to reach a district hospital from different parts of the district.
Right.
Okay, and you mentioned that you have talked about the median duration of admission and waiting times for the entire study. It will be interesting to see what was the waiting time like at different facilities, and and that could possibly be one indicator to see how well the referral services are functioning at different health facilities.
Right.
I'm sure you would have the information with you in any case. It's good to know about that in the paper.
Right.
And another thing is about the transportation system itself. You mentioned that this Janani Express, which is being provided in the state, it will be good to know, what sort of vehicles are there, what are the availability like, issues like how acceptable they are to the people, and because I was a part of the review mission in Haryana, and they came up with a similar system. They were basically retrofitted Maruti Omnis, and oftentimes there were only one or two, one at each facility, and sometimes when there was another vehicle which was not available, then this vehicle was seconded to the disease control programs or whatnot. So it will be good to see what kind of functioning was happening. How is Janani Express itself functioning? So so within your Jan's framework, the transport component, having more detail about that could be useful as well.
Right.
So yeah, more or less these are the points, and I think it's a wonderful study. You've identified a very interesting area to work in, and I think the more issues you investigate at the systems level, it might be more useful to the policy planners.
Right. Yeah. So I'm glad that we had these new points to think on and maybe plan further studies on these issues. Just to share that about the Janani Express, we have another PhD student, a friend. She's looking at the transport. Her thesis is focused around the transport for obstetric services. So she's looking at the Janani Express company. And there's Vishal and other colleagues who are looking at the use of GIS for the quality of road and positioning of those vehicles that you mentioned about. So yeah, we are trying to look at different aspects in ways that's possible. You've given us interesting points to think about, especially the acceptability of vehicles. When I went to Uttarakhand for my past work, they have this large 108 vehicle, and it comes with that alarm that when it reaches households. So women really don't wanted to announce that she's gone into labor and the vehicle has come to pick her up, and it's a big ambulance kind of thing. There are small things that affect acceptability, and then that will impact the outcome. So they are important points that you put to us.
Okay. So
Excellent.
Thank you, Abbas, for your comments. And now, if there is any question from audience, you're welcome to ask. Any question? Anything you want to share about referral service?
Hi, this is Mira. I guess I'm a part of the audience today, and I would like to thank Sarika for very interesting presentation and for very interesting discussion. Also, thank you, Abbas and Sarika. I don't have any concrete questions as of now. It's just my appreciation and being a part of this. Thank you so much.
Thank you, Mira.
Thank you. So then I close the session. Thank you very much. Thank you, Abbas. Thank you, Sarika.